Good evening, everyone. This is Bassem Abdulmalik, SAMBA President. I'll be moderating and answering some of the questions for tonight's town hall meeting. So we titled tonight's webinar as All Things COVID-19, and we're going to have a special presentation by an expert in COVID-19 testing. We'll get to that after the introductory slides. First, we'll start with the legal disclaimer. I would like to give you a couple of minutes to read that. And as you read that, I want to remind you that there's a control panel right upper corner of your screen where you will find a chat box and question box. If you have any question, please post it there. If you have any comment, please post it in the chat. Or if you have any technical difficulty, please post also in the chat. And our staff will be monitoring that. Will be able to assist you with your issue with the webinar. So before I start tonight's webinar, I just want to remind you of a few things. We have posted a few statements on our website that relate to what's happening around us with the COVID-19 pandemic. I hope that you find this helpful. This one here relates to resuming ambulatory anesthesia care, elective cases, and so forth. The last one we posted a couple of days ago relates to testing, pre-operative testing before ambulatory anesthesia. We hope you'll find that helpful as well. We're going to have a lot more on that topic tonight as well. As you all know, we had to cancel our in-person meeting because of COVID-19 travel ban. So we had to move into a new era that we've never been before, but it sounds very, very exciting. And from what I've seen so far, it's really, really amazing. It's a virtual experience. It's not a Zoom. It's not a webinar. It is something unique where you're going to be able to attend lectures, going to have side Zoom meetings with your colleagues, one or two you want to chat with and comment on what's being said. Going to be able to visit the virtual exhibit floor. We're going to have opportunity to meet with our exhibitors out there in those virtual rooms and so forth. It's going to be fantastic. So I hope you will find the time to join us. It's only in the weekend at a very, very discounted price, and members get it almost for free. So please join us for that exciting experience. I understand, I know that many of you are our members, but some of you are not members. Please join us. Consider joining SAMBA today. As you all know, societies do require some funds to keep running. We have management company, we have technology that we use and so forth that we have to pay the bills for, and we would appreciate your support to be able to provide and continue to provide these free webinar and other services. But there's lots of other member benefits. I listed here just a few of them. The huge discount that you get at annual meeting, if it's in-person annual meeting, is equals to your annual membership fee. Discussion forums available for all. You'll be connected with the nation's leaders in ambulatory anesthesia. Education, obviously, we keep doing that, and webinar series, COVID-related and non-COVID related. We have some of them posted on our website already. Research awards, we have those for those of you who are researchers. We even have a research grant that we announced just about a couple of months ago that you can apply for. Professional development opportunities are huge. We have many of our members, because of what they do for SAMBA, because of their connections with SAMBA, we're able to get some reference letters and got promoted to higher academic positions if that's what you aspire to achieve. We have lots of leadership opportunities as well in our committees and our among officers and board of directors. Networking is unparalleled opportunity. It's big enough conference and group and small enough that you still get to meet with people and get to know them and get to know you, and it's just fantastic opportunity. We have also established recently the distinguished SAMBA fellow status. There's certain criteria obviously you have to fulfill before you are able to get that, but is something that is not impossible to get. It's something that you would be able to achieve in a few years if you join us, if you are a new member with the organization. So again, the website is www.sambahq.org. Please join us. We'd love to have you as a member. The board have posted for you a COVID-19 resources page. It's right on our website. This one is not limited to members. Any one of you can join there, so please share freely and widely. There's lots of resources there. And one of the resources there is the webinar series. Today is number 6. The 5 prior webinars are all posted there, videos and slides as well, if you are inclined to review and watch and enjoy. Tonight's webinar also will be recorded and posted, hopefully by the end of business tomorrow. With that, we'll get to tonight's webinar. Tonight's number 7. Excuse me, I want to announce next webinar, which is going to be number 7. That's going to be Monday, 5/18, 7 to 8:15 p.m. as well. We're working on the agenda for that, and speakers will, once confirmed, we'll get that to you in a day or so. But please mark your calendar. Will be the same day next week and the same time as well. We'll send you emails with that once we'll finalize the arrangement and so forth. Tonight's webinar, though, tonight is number 6, all things COVID-19 town hall, where we're going to be answering questions. We have received a lot of questions from you. However, if you still have other questions that you want to post or you have not had a chance to submit your question, you can do that today at the question box right there. We'll be monitoring that, and they will get to me immediately. So today, in addition to the questions and answer, we're going to have a special presentation on COVID-19 testing. With that, I would like to introduce our speaker tonight, Dr. Brian Rubin. Dr. Brian Rubin is a professor and chairman of Thompson Pathology and Laboratory Medicine Institute at the Cleveland Clinic. He's one of my colleagues working in the same institution. He's the expert in his field, especially in COVID testing, with what's always happening lately, and he will be sharing with us his knowledge and information about the truth about COVID-19 testing and all, and he'll be happy to take your questions as well. After that, he will join us, as well as tonight's panelist, yours truly, as well as Bobby Jean Schweitzer. Dr. Schweitzer is our SAMBA Vice President, and Dr. Leo Rodriguez is the SAMBA President-elect. We'll be answering a lot of your questions that we received from you and those that we had not had chance to respond to in the prior webinars when we ran out of time. With that, without any further ado, I'd like to reintroduce Dr. Brian Rubin for his presentation on all you need to know about COVID-19 testing. Dr. Rubin?
Thank you very much for that kind introduction and the invitation to speak with you tonight. I only have a few slides to start with, but then I have some more as we get into the questions. So I'm going to be talking just some overview of SARS-CoV-2 COVID-19 testing. There we go. Okay, so I kind of broke it into different kind of areas. And so testing for acute infection is sort of the first stop on the testing bandwagon. And there's really 2 major types of testing that are used. The first is a PCR-based test. That's the most common in academic medical centers. It detects viral nucleic acid from a variety of different sources. So nasopharyngeal swab would be the most common, nasal swab, throat swab, sputum, and some of you may have heard about saliva as a new specimen. The virtue of this test is that it's got really high sensitivity and essentially 100% specificity. It comes in 2 flavors. There's a rapid variant, and so it would be exemplified for something like the Cepheid Gene Expert. Everybody's become a testing expert these days, so I bump into people from all walks of the hospital, and it's amazing how much they know about testing and telling me about machinery and so forth. So maybe some of you have heard of the Cepheid. We use them here at the clinic, and they're fast. The analytic time is about 45 minutes on that. And then our major platforms are non-rapid platforms. And for instance, we use something called the CDC assay. That's the standard Center for Disease Control assay. It's a RT-PCR based assay. And the analytic time on that is quite a bit longer because it's a very manual assay. It takes about 3 hours, but we typically have a median turnaround time of about 14 to 15 hours from the time of collection to when we result that test at the clinic. Now, another one that's really been in the news a lot, you've seen it, the president's been using it, is an isothermal-based test. And an example of that would be the Abbott ID Now. So that's been used by the president. And that's a direct detection kit, essentially. It's really fast. It's 15 minutes, and it basically just detects the nucleic acid of the virus directly from a nasopharyngeal swab. The beauty of this test is that it's point of care, which means it's portable. I could literally carry the machine around with me. It doesn't weigh that much. Super fast, takes about 15 minutes. But as you can imagine, you sacrifice a little bit of performance with a really fast portable test. And it's not as sensitive as PCR-based tests because there's no amplification step. It's really simple. When you amplify, you increase the sensitivity. No amplification, sensitivity goes down. This is what a real-time PCR scan looks like. And so you can see here, this is baseline. There's no amplification here at all. But then when the specimen starts getting amplified, we can detect it. And so this is the cycle threshold here. That's the minimum cycle that we can actually start detecting a positive. And we run a lot of validations in our laboratory to determine where this cycle threshold starts. I'm going to show you something here that kind of puts it in a little bit more of a context. And so here you can see various, here's the cycle threshold, and here's amplification curves for several different samples. They're overlaid over top of each other. And so this early curve means that there's a lot of virus in this specimen. So when you see an early curve, that means lots of virus. When you see later curves, that means lower virus. And so this is where you get your false positivities over on the right side here, because essentially you're measuring a very late threshold, and if you have contamination, you'll see it there. So talk a little bit about serology. So serology is purported to be used for diagnosis, assessment of immune status, convalescent plasma for treatment and prophylaxis, vaccine immunogenicity trials, and surveillance epidemiology. It's kind of the test that has the potential of doing it all. However, serology's got a lot of problems. So the first is in diagnosis, and I'll show you another curve here, another graphic in a moment, but it just appears too late for acute diagnosis. You typically don't see serology until 10 days after, well, really 10 or 11 days after symptoms. And so it's too late. We want to know way earlier than that. So it's not useful for acute diagnosis. It also has serious problems with lack of specificity or cross-reactivity. And so common things that it reacts with are anti-nuclear antibodies, a recent flu, and then a variety of infectious diseases, which look a lot like COVID, including the common COVIDs. And then finally, the correlates of immunity are unknown. We'll get into this a little bit more. And so here's kind of a nice graphic that a friend of mine gave me. And you can see here, I hope you can see my pointer, but over on the left side, if you can't see it, the pink, red, blue, even this yellow here, these are all PCR-based tests. And so here's where symptoms start. The virus is, patient gets infected. Here's where the symptoms start. And so you can see all these tests are really sensitive, and they can pick up the disease very early. However, here's where your antibodies start kicking in over here on the right. And so you're well into the disease before you can even start seeing antibodies. And so that's really a problem for diagnosis. And so typically we don't think of this as playing a role in diagnosis. And here's the scenario I always get asked about. So a patient or a family member or one of my colleagues here at the clinic will say, I really want to get the antibody test because I think I might have already had COVID-19, and it would be such a relief to find this out, know that I am immune so I can go to work without fear. And this is where the problems kick in. I agree, that would be fantastic, and I wish I had the test that gave people that information, but there's two problems. The first is lack of specificity. So in a low prevalence disease, the test has to be perfect. It has to be 100% specific. And it's not. The most accurate test, and really it's a stretch to say it's 99% specific because we don't really fully know, but let's just say it's 99% specific. In the positive predictive value in a population with 1% prevalence is 46%. That means it's a coin flip. It's actually worse than a coin flip. for me to tell you whether you're seropositive or not using the best test on the market today with a 1% prevalence. Unfortunately, we think the prevalence in Cleveland is around 0.3%. With a 0.3% prevalence, the positive predictive value is 15%. That means I do that test, I've got a 15% chance of knowing for sure that you've got antibodies to COVID. Worse yet, even if it's a true positive, let's say I've got the perfect test, it's 100% specific, it's always 100% specific. That's a test that doesn't care about prevalence because positive tests are always perfect. If it's a true positive, we don't know what that test means. We don't know whether you are immune, and that's because we don't understand the biology of this virus that well. So this just kind of lays it out a little bit more. So is IgG serology a reliable option for COVID-19 immune status check? We want to know, individual immunity return to work. This is the most common scenario. I get asked about this probably 10 times a day. So again, beyond the false positives, we just don't know whether the presence of antibodies correlates with clinical immunity. And in fact, in coronaviruses in general, immunity is short-lived. But then again, we don't know anything really about immunity in coronavirus, COVID-19 yet. The correlative protection is not known. That means, what is the correlation between antibody status and protection? This has to be established via large and well-designed controlled trials. Common examples, the things you guys know about, is hepatitis B, for instance, surface antibody that has a 10 milli-units per milliliter. Rubella IgG, again, 10 international units per milliliter, sorry. And those we know those prevent infection, but those are based on really, really well done studies, lots of information. We may get there, but it's gonna take time. And that's the bottom line, is that, we're in a situation where we wanna rush and interpret things, but in fact, we just don't have the basic biology at this point to really understand. So the bottom line for serology at this point is that it's not useful for diagnosing acute COVID-19 infection. Remember, the antibodies just occur too late in the disease to be useful. Population and individual level of immunity following exposure to the virus is unknown. The role of antibody testing in particular populations needs to be defined through targeted serosurveys. You're starting to see some serosurveys now coming out for the Center for Disease Control. However, they're gonna overestimate the prevalence of COVID because the tests are not 100% specific. In fact, I would be surprised if their test was over 95% specific, but I don't have the data of the exact test that they're using. We are testing them at the Cleveland Clinic, but we haven't brought them online yet. The role of serology in convalescent plasma therapy is not standardized yet. Again, there's a lot of ongoing studies that will get to that. That'll be a nice use. And then serology will definitely play an important role in vaccine trials, but we are not offering serology, to be specific, at the Cleveland Clinic currently in the diagnostic setting. It's only used in the research setting. That may change as we learn more about the virus. And I always tell my colleagues, I'm happy to bring on serology the moment that I think it will play a useful role in the diagnosis and treatment of patients. So that was kind of my initial primer. And I don't know, Bassam, do you want me to answer questions now, or how I can't remember exactly how we were going to proceed, but I think you wanted me to maybe address some questions. Should I just read them? Okay, well, why don't I start reading the questions? So I received 4 questions.
Bassam, you are muted. If you could unmute yourself, please.
I think he's still muted.
Dr. Rubin, I just, oh.
I'm going to just read the questions and answer them. Okay, why don't I start doing that?
Okay, well, I got you now. Can you hear me now?
There you are, Bassam. Yeah.
Okay, I just want to say thank you for your presentation. We appreciate it. And that adds to what we have tried in the past. We invited a prior expert in infectious disease, Dr. Mossad, who gave us some valuable information about the virus itself and its transmission and so forth. And what you told us today add to that base knowledge that we learned quite a bit from you and from him. So we have received a few questions, and I wanted to wonder if you would be able to help us out with that. Any evidence for how many days pre-op we should be testing patients for COVID-19 before starting elective surgery?
Yeah, so I mean, there's not really any evidence for that that I know of. And so what everybody's sort of locking in on is 2 to 3 days before surgery. It's almost an operative thing because people don't have tons of rapid testing, which would be ideal. If you had lots and lots of rapid testing, I think you could do it a day before surgery or even same day, because then you'd really know right away. What we're doing at the clinic is, because of the fact that we do most of our testing in a non-rapid platform, we ask for 2 or 3 days, and essentially we ask for 72 hours. But it's really just because we think that's close enough where the result is pretty realistic, and that patients won't come in with false negatives, but it's long enough time to give us the operational time to do the test.
Thank you. And just to add to that, we also...
Hello, this is Leo Rodriguez. I wanted to add something to that. That it's really important that when the sample is taken, that we recommend that the patients self-quarantine so they're not exposed to the virus after the test is taken.
Thank you, Leo. That's an excellent point. Yep.
Now, if you have an employee that was exposed to COVID-19 15 days ago and still no symptoms, when would you test?
Yeah, so we don't test asymptomatic caregivers at the Cleveland Clinic. I mean, I can show, I have a sort of a smaller presentation. I can give a little bit about what we're doing in terms of testing at the clinic, in terms of caregivers and so forth. But and maybe I should do that. But to be specific, we don't test unless people are symptomatic. And if somebody's quarantined or isolated, really quarantined for 14 days, they can come back to work at that point. And so that would be a patient that could come back, and we wouldn't do a test. Let me, why don't I present a little bit more maybe related to this question and a couple of the other questions, because I know you guys are very interested in that, in this kind of area. So can you see my desktop still? All right, so yes, for monitoring healthcare workers, again, we don't do any testing for asymptomatic healthcare workers. It's just not recommended at this time by our infection prevention and infectious disease colleagues. We focus on the fundamentals, so we use standard precautions, hand hygiene, isolation. Expect this of yourself and your colleagues, keeps patients safe, keeps you safe, and it's really a clinical competency issue. So instead of testing, which most places don't have enough testing to start testing groups like this, we emphasize the basics. So again, standard precautions. For isolation, standard precautions apply to all situations. Isolation does apply to specific situations, a known or clinically suspected infection, kind of like the last guy we talked about. Once they're done with 14 days and they're not showing any symptoms, of course, they can go back to work. Isolation practices apply the same tools as standard precautions. So hand hygiene, PPE, we put a really big emphasis on this at the Cleveland Clinic, and isolation practice built on the foundation of standard precautions. And I have to say, I actually think our hospital is safer than being on the outside right now, because when we look at the number of physicians and caregivers that have had infections, it's less, but the percentage of positivity is less than the general population of Cleveland. And so I think all this works, and we definitely haven't been testing people unless they're symptomatic. Because cough etiquette, so universal masking of patients, which we don't require masking of patients in our facility, but we encourage it. But we do require masking of all healthcare workers now. And so everybody in our setting is wearing at least a cloth mask at all times. And except for when you're office, like I'm at work now, I'm in my office, but I'm alone. I won't wear a mask in here. And then we pivot to PPE as dictated by the clinical situation. One of our ID guys gave me this. You know, it's kind of not really about me in the pandemic. It's about you. It's about other people. That's why we wear the mask. It really protects everybody else, not yourself. Now, just to get into the criteria kind of this is for infected healthcare workers that return to work. So originally there was the 7-3-2 strategy that was recommended by the CDC. So it was 7 days since the onset of symptoms, 3 days since improvement in defined symptoms, and then 2 negative PCR test results 24 hours apart. But we did actually a study here. I think it's been submitted now. And we looked at this. And the problem is that the virus can actually hang on for quite a while. And so it creates this problem. And so I think here we go. So if you look at this, in fact, these are, you know, box plots showing early on in the infection, here you have a lot of virus. And then every few days, it basically decreases by about 64-fold. And then after the first 14 days, it decreases a little bit less, but it can really hang on in this phase for a really long time. We've had some caregivers and patients who've remained PCR positive now for like 6-8 weeks. And we don't think that people at this stage over here on the right, where they have a very low amount of virus, are infective or infectious. And there's actually a lot of data to support that. So the CDC actually updated the return to work criteria for healthcare workers, and we're following a non-test based strategy here. We just found the test-based strategy was really a problem because we had so many caregivers with low-level viremia that just wouldn't eliminate itself over a long period of time. And again, it's just a positive PCR result could represent non-infectious virus. We think that's what's going on in the in caregivers and patients who have had an infection. And so we think post-symptomatically that the virus, a low virus, doesn't really mean anything. It's non-infectious. So we now, this is the Cleveland Clinic strategy. We have what we call a 10-3-2 strategy, non-test based. So 10 days since onset of symptoms, 3 days since recovery of symptoms, and then followed by 2 weeks back to work, mandatory cloth mask with no testing requirement. We actually ask caregivers who are patient facing to spend the first week back doing something else that's non-patient facing. Now, what about patients with COVID-19 and discontinuation of isolation? So there's no non-test based guidance right now for patients at this time. You still require 2 negative tests 24 hours apart. And again, we've had some patients who really linger for a while. So we think that what's going to happen over time is they'll probably move towards 28 days from positive test with clinical resolution of symptoms to remove isolation precautions and need for PPE. I think that's probably where they're heading. Okay, well, that was what I had to kind of about that area.
Well, thank you very much. You actually answered the next 2 questions, which about routine serial testing for positives and also recommended testing policy for staff. So we appreciate that. That was very helpful information, especially the CDC updates and so forth. We appreciate it. Now I invite the other 2 panelists, Dr. Rodriguez and Dr. Schweitzer, to join us, please. We're going to go through a bunch of the other questions. Dr. Schweitzer, would like to have your slides up. I have a question that you kindly prepared the slides for, which says, can you address the types of filters that would be the best for anesthesia machines?
Yes, thank you very much for that. Can you see my slides?
No, I see the part. Yeah, now I see it. Thank you.
Okay, let me be able to see my slides, hopefully.
Yes.
So the best filter, pardon me?
Yeah, it went away. Not that one.
It went away.
Yeah. Now we see the.
Now you see the slides?
Yes. Can you go to a slideshow, please, from current slide?
here we go. Okay.
Yes.
So there's what you want to look for is a virus filtration efficiency rate of 99.99%. This is the most common filters that we're routinely using in our anesthesia machines. But there are basically two essential filters. Some are them for humidity, and those tend to be much more mechanical filters, and they're pleated. The problem with those is they tend to maintain humidity better, and they filter just as well for viruses typically, but then they become loaded with water, and then they increase work of breathing for their patients. So generally, they recommend that those mechanical filters will work to both maintain humidity as well as filter viruses very, very effectively. You just may have to change them more frequently, or you may have to be careful about the work of breathing of the patients if you're not actually mechanically ventilating them, if you're letting them spontaneously breathe. They're a little bit more effective than electrostatic filters, but frankly, the electrostatic filters are generally considered pretty much effective. So I think probably whatever you have that you routinely have been using will be fine.
There's also another question about where actually to put these filters in the circuit. Is the current position at the Y connector piece satisfactory?
So there's two things. That primarily the filter is there to protect your machine. So if the patient does happen to be infected and they're expiring viral particles, if you don't have a filter on, then between the patient and your machine, it's going to infect your machine. And then your machine has to undergo significant internal cleaning processes. So ideally, if you're going to have one filter on, you put it right where I show you here at the YT piece. It's right at the at your endotracheal tube and before your inspiratory and expiratory limbs. And you want to have the gas sampling line on the opposite side from the patient of the filter, because you want to also keep your gas sampling line clean as well. So occasionally there's setups and occasionally filters won't allow you to do this. So if you're not, be aware that if you're not keeping your gas filtering line clean, then you want to do something about that. Now, another question always comes up is, should I put a second filter on, and should I put it on the expiratory limb? This is probably not necessary, though if you do put two filters in place, if there's any virus that does happen to get through that first filter, it will then be caught by that second filter. And then you will just ensure a little bit more insurance that your machine is going to stay clean. There doesn't seem to be any advantages of putting it on the inspiratory limb, and that would require a third filter, and generally people are wanting to conserve resources to some degree. So it's probably effective to use just one filter at the Y piece, but have it closest to the patient as you possibly can, because the idea is that you're protecting your machine and all your sampling lines. If you're going to use a second filter, put it on the expiratory limb down where it connects to the machine itself.
Thank you. I think I've used this strategy with two filters when I had a COVID positive patient, and another time when I had a PUI under investigation. But the average patient, I use personally one filter only at the Y piece. You just explained to us. So thank you for that detailed answer. We have another question that actually has many questions about the same topic. For example, one of them says, please discuss GI endoscopy turnover time and air exchange between cases. Currently, we're told that we need more than 1 hour. Other questions down the same line says, what's best practice for OR, procedure room, air turnover? And the other one said, I've seen recommendation from 30 minutes to 3 hours. Any comments on that? So these are all the questions about the same topic, which is about room air turnover in the operating room and procedure suite. Can you please comment on that?
So I'll show you a couple slides I have, and then I'm also going to have Leo weigh in here as well. So I think the key concept here is that you need to understand how many times per hour or what the air changes per hour is within your OR settings and OR suites. And these all vary somewhat by regulations that are local or state and the age of construction of your facility. Older construction facilities allowed the air exchanges to be less efficient, and it took longer to exchange time, so it's going to take longer. Newer construction tends to exchange that faster. But here's some examples, and I put the URL here for you to go look at this. If you look at it, it tells you, and you should be able to get this information from your engineers and your facility of what the air changes per hour are. And then you can look and see how many minutes it takes to get 99% efficiency. Remember, the idea is that, our masks are supposed to be helping us get 99.9% trapping of this virus. So that's usually one of the sort of targets you go for is 99% removal. Now, remember that this is after you've sort of cleaned the place, right? It's not, so if you had a patient who did have COVID, they're in the room with you, they're aerosolizing perhaps, these viral particles, particularly at the end of the last aerosolizing procedure, which if the patient is intubated would be the extubation. So then the time starts right then. It starts at the very last aerosolizing process, or when the patient's left the room. And then your staff has to come in and they clean stuff. And as they clean, they may be stirring up particles, right? Viral particles, off the floor. They're scrubbing things or wiping things down. So then some people say, you start the time at the end of the actual surface cleaning. If you want to be sure you remove everything. Now, again, these are probably only these extensive times when you absolutely have a COVID positive patient and you absolutely need to turn that room, completely clean. So typically people talk about doing what they call terminal cleaning after COVID patients. Typically you're not doing these patients in your ambulatory surgery centers at all, ideally. But if you did happen to discover a patient that, was COVID positive, or you did end up doing one, I think you would be concerned about making sure that room has some additional time. Here's just another example from that website where you can look at different kinds of, situations, what it gives you, like a bronchoscopy and endoscopy. The longer the patient's in the room, the more aerosolizing, procedures that are taking place. The longer those aerosolizing procedures are, the more virus that's going to be out there, and the more virus has to be removed from that room. Simple intubations and extubations have actually been somewhat questioned now about whether they are truly aerosolizing procedures. Apparently, it's based on one World Health Organization study that was done, and almost everybody else just keeps citing that one study over and over again. But some people have actually questioned how aerosolizing truly intubation and extubation are. Leo, do you have anything to add to that?
No, I do not, Babijina. I think that this applies depending on what philosophy a facility is applying. So let's say that theoretically we were testing every single patient, and every single patient were negative that would proceed with a surgery in an outpatient surgery center. Then, in this case, we would follow regular procedure. However, we hear from our previous presenter that there are false negatives and false positives. So, we're still relying on screening the patients for contact and symptoms. And then most facilities are doing the PCR 2 to 3 days before the procedure. We're asking the patient to self-quarantine. And then becomes the question of judgment from the facility leadership. Do they want to consider all patients carriers, or do they want to trust the negative test and rely on the information? And that's that's where you have to look at your community. So if you have a community with high prevalence, it's very likely that you're managing patients that are carriers. And if you're in a community that you have low prevalence, it's the opposite. And then based on that, you have to use your judgment. I do the opposite of what you do. So we do the procedure, we extubate the patient, When we extubate the patient, we have a plastic bag on the patient's face, and we quickly turn into a mask. And once we make sure the patient is supporting their airway is spontaneously without any aid and without oral airways, we take the patient out of the room, and then we leave the room closed, and we wait the amount of time that this table recommends. The operating rooms, as you said, the older operating rooms, they have about 20 air exchanges per hour, and the newer operating rooms, they have about 25, even 30, I've heard, exchanges per hour. So obviously, depending, if you have that, you have a quick turnover time. And then after that, then the cleaning team will come in and clean the floors of the room. In the GI rooms is where the problem is. So GI, the ventilation is very poor. Usually in the old code system, they were using 6 air exchanges. And I think that's where the question comes from. Because when you have 6 air exchanges, in theory, you have to wait 46 minutes. And that can cause a lot of problems. So again, you have to go back again to your philosophy. And what are you thinking that your patients are negative, or are you thinking that your patients are carriers? And then you make the decisions based on that. I don't know if Dr. Rubin has anything to add, or
no. Well, I agree what you said about prevalence, and you got to know what's going on. The other thing is that you can ask your testing community, the people who are doing your testing, how many false positive or false negatives they're seeing, and so or asymptomatic patients. And so I think the asymptomatic patients are the most interesting. So we actually started tasting all of our ASC procedure patients as well as all of our OR patients last week. And so we've been doing it for about a week, and we found that about 2 to 3% of our patient population were asymptomatic. And I think that's good news in a way, because it's not as many patients as a lot of people thought. Many people I talked to thought, half the COVID patients were walking around as asymptomatic. And now that we've started to look at that group, we're going to do some research on them. What we found anyway, in at least the first several that we looked at, is that they're actually they're post-viral. When you talk to them carefully, they had something maybe 2 or 3 weeks ago, 4 weeks ago, some viral sounding thing, and they just kind of forgot about it because they were no longer feeling the symptoms. And so again, I think that kind of tells us that the number of patients who come in who haven't declared themselves as having the disease yet is really pretty low. And so that's good. That's good news in a way, because I think that those are the ones that we would want to worry about the most, because people are more infectious early in the disease. And so that's the one. And we, in the testing community, we're really spending a lot of time thinking about how we can identify that group of patients. So the other point is, and I think you made this sort of, is that you just have to be a physician. And if somebody looks like they might have COVID, but they have a negative test, treat them as if they have COVID. Don't assume just because it's a negative test that they really truly are negative. You have to stay on your toes.
Thanks, Brian, for that note, because which brings us back to what we had before, and we might have today as well, that we may have some different answers to the same questions. They just told us that there's diversity of practice out there, and physician judgment supersedes every guidelines out there, depending on the situation that you have and what you see and the community and so forth. And we intended to have multiple panelists just to share some of the diversity out there in practice and clinical care of those patients. We received many actually testing questions. I hope the panelists will be able to help us out with those just now. So what is the most common test in the community now, please, Brian?
The most common what?
The most common test in the community.
Well, I think it depends what kind of community you're in. So at academic medical centers, it's definitely the high-end RT-PCR based, semi-manual tests. Everybody wants to use machinery and gear to do testing. Like there's Roche makes, the 8800. That's kind of the best and biggest of the devices that can test 2,500 to 3,000 tests a day. It's fully automated, but it's really difficult to get a hold of those because they don't make very many. So most of us are just using standard RT-PCR. Now, out in communities where they don't have a sophisticated testing group, so small hospitals, community hospitals, which might not even have a microbiologist on staff, for instance, They'll use the more automated stuff like an Abbott ID Now, or one of the self-contained things like a Cepheid, something that's relatively low complexity, low to moderate complexity.
And the other one you already answered, are you testing everybody within 72 hours? The answer was yes. If negative COVID test, what type of PPE are you using? Maybe you can ask Leo and Bobby Jean on that. If the negative COVID test, what type of PPE are you using? And the follow-up to that, LMA or general endotracheal anesthesia?
In our facilities, we're thinking that because our community in Miami, we have a high prevalence still. So we treat every patient as if they were a carrier of the virus. So everybody in the clinical areas wear masks, surgical masks, and everybody that's in an aerosolizing procedure, even if you have a negative test, we're gonna wear N95 mask and shield and goggles and the gown, and we're just treating, trying to protect the staff. That's the main principle in our facility was protect the staff so we can protect the patients.
Awesome. Bobby Jean?
It's similar in our situation as well. Everybody, I think we have a very high prevalence. I'm in Chicago, and we assume everybody is a person of interest and concerned a bit about the false negatives, as well as the asymptomatic carriers, and we're testing 72 hours ahead. And even though we're asking people to self-isolate, that's not a guarantee.
All right. In our case, we do with, depends on the procedure. If it's aerosolizing procedure, which includes intubation, extubation, bronchoscopy, endoscopy, ENT surgeries, all those requires N95 and so forth. If it's non-aerosolizing procedure, surgical mask is good enough. So that's how we approach that process for COVID negative patients. The other question I have here, if testing is not available on weekends, should we bother testing Wednesday and Thursday? We're currently getting results in 48 to 72 hours.
Yeah, we have been doing that because it's not available on the weekends. So, for a Tuesday endoscopy, upper endoscopy, we're testing patients either Wednesday or Thursday. And then we tell the patients you have to self-isolate. And some of them don't want to. And I say, well, you still have to do a bowel prep. Are you going to do your bowel prep in the street? No. So, it's, they have to realize that they're exposing other people. So they have to take responsibility for their actions.
Yes. Question to Brian. The question saying here, since there are false positive serology tests, is there a better test that could be used for donating convalescent plasma and being used for treatment? So how would you determine that somebody had the virus so they can donate plasma that now they're under trial for treatment in ICU?
Yeah, so currently the requirement for donating convalescent plasma is just that you've had a documented disease. And so that means that at one time you were tested, you were positive, and now you're post-viral non-infectious. And so that's the current requirement. Now people are studying it. And so, this is where the study of antibodies comes in. And so people are looking at the serological tests that are available and trying to determine whether, for instance, a certain titer of antibody will equate with, a better result. Logically, that would be the case. The more antibodies, because you assume that the whole purpose of this is that the antibodies would neutralize virus. And so that the logic is that's how it should work, but we don't know that for sure. And so again, these things are just currently under study. And so I'm not aware of people who are analyzing plasma with antibodies as a requirement for doing convalescent plasma. We're part of the Mayo Clinic consortium here at the Cleveland Clinic, and we're working with them to study convalescent plasma and find out even if it's useful. It may not be.
Thank you. So what should be the testing strategy for a patient who tested positive and had their surgery, elective surgery postponed. Should we wait 14 days and retest?
For an elective surgery?
Yes.
I would,
Somebody
yes.
coming for elective surgery and turn positive.
Yes, asymptomatic. I mean, I would, for us at the Cleveland Clinic, it's 14 days. They have to be symptom-free. Yeah, cannot come back for their surgery, for elective surgeries.
Do you retest again?
We do. We have to have 2 negative tests.
Okay. The question is now, how is antibody testing helpful for patients having elective surgery? I think you mentioned that that's not helpful.
Not helpful at all.
Which type of testing is indicated, the antigen testing or the antibody testing?
Okay, so, well, maybe they're referring to the subtleties between there is a newer antibody test that just came out, and so antigen testing is serology. So that's looking in people's blood for antibodies. It'll react with an antigen that's bound to a plastic plate. Now there is a company that just got FDA approval on their EUA, company called Quidel, that makes an antibody test, which is a direct point of care test. So you take a nasal swab and the antibodies are to virus. And so that's a diagnostic test. We haven't tested it specifically. It actually just got approved over the weekend. But based on other experience with similar tests, it's going to be a point of care test with a relatively on the low side for sensitivity. And so the sensitivity will probably be about 85 to 90%, probably better in the ambulatory setting and not as a screening procedure for surgeries. I would think if patients are going to surgery, going to things that where they're going to have their there's going to be aerolization, that you want the best test you can get, which would be the high-end, real-time PCR-based testing if you can get it. But any test is better than no test, in my opinion.
Thank you. There's a question here regarding LMA versus intrathecal tube for general anesthesia and its relationship to aerosolization. I'm happy to answer that, and we'll take some more comments from Leo and Babiji. I think the issue is that you have to weigh the benefits and risks. So LMA, if it doesn't sit well and it's leaking, probably there are some concerns about aerosolization there. Intratracheal intubation, if you are not utilizing a technique where you can achieve coughless or smooth extubation, as we call it, then that probably might carry some risk as well. So if the LMA sits well and does not leak much and so forth, you might be okay with that. Intratracheal tube, obviously, it is the ultimate ever securing that, but also you have to put in consideration that if you do so, you may want to use some of the techniques that we all generally use in ENT, where we strive for very smooth extubation with no cough or bucking or any of that sort. Leo and Babiji, would you like to add some more to that, please?
This is Leo.
So
I agree. Sorry, go ahead, Babiji.
Sorry. So for my typical, supraglottic airway, I let the patient spontaneously breathe. So I don't use positive pressure ventilation. And it seems to me just common sense. I don't have any data to draw upon that would be not an aerosolizing situation. And I think that if you do avoid coughing, as Dr. Abdullah alluded to, then you're going to decrease the aerosolization when you remove the supraglottic airway, if the patient's not going to be coughing. So I agree that I don't think that one has to completely avoid supraglottic airways, particularly if you have a patient that is, denying symptoms and the patient tested negative and you're in a, fairly highly reliable test, and the patient is undergoing a procedure where there could be benefits of avoiding intratracheal intubation, or if that'd be your routine practice to avoid intratracheal intubation. And I think it's reasonable to go ahead and do the supraglottic airway.
Thank you. Leo, do you have anything to add, please?
I agree. I do use LMAs, and I keep my patients breathing spontaneously. Some people are addicted to positive pressure ventilation with LMA insertion. I don't think this is the appropriate time because we don't know if patients are carriers, and I recommend spontaneous ventilation. Limit your narcotic utilization. Use multimodal analgesia and regional anesthesia, and you're going to stay out of trouble.
Thank you. So now we have a question for Bobby Jean. In gynecology, we will use a simple face mask and 4 to 6 layers of oxygen for COVID negative hysteroscopy procedures. Are there any concerns using oxygen in the office procedure room for these elective procedures?
Can you see my slide there?
Not
So
yet. You're getting it now.
Okay, great. So I put up a slide here that I took, and I have the reference there for you to look at if you want to read more about this. You know, we sort of have, everybody's been saying that intubation, extubation is aerosolizing and that all these different procedures are aerosolizing, but there's actually minimal evidence to actually know which procedures are aerosolizing procedures and which are not. And we don't even know, you know, what sort of size of particles, you know, for example, measles apparently can be, you know, carried very far on air currents. We don't think that this virus is carried very far. We think it probably is carried at very short distances, actually. So I'm not sure what one, you know, how one can sort of decide whether oxygen use or not. But we do think or concerned most about things like where there's actual sputum induction, where you're suctioning patients, where you're down in their you know, airways, if you're doing fiber optic bronchoscopy, particularly if you're, you know, suctioning and you know, if you don't have good seals. So for example, with the BiPAP, if there's a leakage around it, if you have very, very high flow oxygen delivery, the chances are you're more likely to aerosolize than with low flows. So I would say that, you know, you probably should stick to your routine practices for the most part, again, in patients who are testing negative and for situations where you have a relatively low suspicion that the patient is COVID positive. But, you know, use the lowest amount of oxygen as possible. A lot of times we just turned up to 2 and 3 liters because that's habit. Many patients don't even need any oxygen delivery. You know, your typical sort of, you know, minimal, you know, MAC case, you can monitor end-tidal CO2 and leave the oxygen off. Monitor pulse oximetry. The patient needs oxygen, give them oxygen. I think this is also, you know, we often give, you know, sort of Big Macs or too much sedation or, you know, a lot of sedation in situations where you don't necessarily have to, just to keep the patient happy, to keep the surgeons happy. The patient doesn't, you know, sort of talk or bother us. But I think this is a new era. And I think, you know, spending a little time with your patient and discussing with them ahead of time, the risks and benefits of why you're proposing a particular practice. But again, I don't think I would, you know, intubate a patient and do a general anesthetic or avoid giving them oxygen because you're afraid of either, you know, you're, you know, exposing yourself or to other people in the room. If everybody is practicing good hygiene, wearing their N95s, wearing their face shields, wearing their goggles, and that sort of thing.
Correct. Thank you, Babaji. I've seen some data saying that if you use 5 layers of nasal cannula oxygen, you will see aerosolization up to 3 feet from the face. So as Babaji said, if you use low flow, 1, 2, 3 liters, you might be okay. So which brings us to the question about regional anesthesia. There's a question here whether regional anesthesia is safe and such. So same thing, if you're going to use regional anesthesia that's effective and working well, and you're going to give some sedation with it, either with no oxygen or low flow oxygen, that might be okay. But if you're going to give regional anesthesia and then you're going to give additional heavy propofol, what's considered general anesthesia without a tube, that you will require a lot of oxygen poor, then you might not want to do that and want to consider other ways by adding a subaglottic airway or even doing general anesthesia and tracheal tube and such. So that's at least my thoughts, my personal thoughts on the matter. Babaji, there's another question for you. So what do you do for disinfecting between procedures? In the room cleaning and scopes and so forth.
So there's several different resources here that I put on the screen. If you want to take a shot of that or later, log on to the recording to help guide you about proper cleaning of either the equipment or your situations. Basically, the best thing to do is remove all unnecessary equipment out of your rooms. A lot of times we use these operating rooms and procedure rooms as storage places as well. And so you've got a lot of different things, and cabinets sitting around that, a lot of stuff in your anesthesia carts. I'm not saying strip it down where you don't have the things you need, but you don't need to have, 10 endotracheal tubes in the room with you. Keep most things out of the room, and then follow basic cleaning recommendations that you should be following on a regular basis for patients that are not having aerosolizing procedures that have been tested negative, that are assumed negative. You probably don't have to do anything differently. If you're doing aerosolizing procedures, that's a different situation, especially if you cannot test or you have a high prevalence disease in your area, and so you're not necessarily relying on your negative test as being, relatively predictive for you. Or if you have a patient that, has some symptoms or exposures that could put them at a higher risk. But good, cleaning processes, and then using an EPA approved antiviral spray is recommended. So I do urge you all to, look at these different websites that I had up there so that you can guide. And remember, we as anesthesiologists are often the people who are anesthesia providers who are actually spreading dirt and germs around. When we first come in the morning, our rooms are often very clean, our machines are very clean, and as the day goes on, everything gets dirtier and dirtier, and we are the ones who are spreading things. So I just remind everybody that, wearing the protective devices or the protective, equipment here does protect you, but then you need to make sure that you're removing it appropriately so that you're not then contaminating things into the removal, and that you're not, inadvertently infecting or spreading it to other areas outside of the operating room, perhaps because you're leaving things on, like your shoe covers as you walk outside, or you're not spreading to the next patient, perhaps because you didn't appropriately exchange your PPE between cases.
So I received a question through, thanks, Babaji. Question to a text thing. There's varying practices regarding managing airways of COVID negative patients coming in. We talked about intubation, extubation being potential for aerosolization. Not very strong evidence, but people believe it does, at least for certain maneuvers. So how would you manage that? How would you approach that? Do you wear N95 for intubation, extubation, or not? So between three of us anesthesiologists in the panel, let's take a poll. I personally do for intubation, extubation. Dr. Rodriguez.
Yes, we use N95 and a face shield for intubation and extubation. In addition to that,
Schweitzer?
Yes, we use the same one. We put it on I put it on the morning, and I wear it all day long when I'm in, so that I don't have to take it on and off. I keep a shield on so that I keep it clean from any kind of overt saliva secretions.
Thank you. So I hope that will answer that question.
I wanted to say something. There's an association called SHA, the Society for Healthcare Epidemiology, and and of America, and they published an article a year ago about infection prevention for anesthesiologists specifically. And this is a very pertinent review article, and people should read it.
Thank you. So we have a couple of questions about, let's say somebody has COVID-19 positive and recover from that and now wants to come back for ambulatory surgery center for having ambulatory surgery. I have two questions here. How long would you wait? The other one, would you wait 6 months? I would say there is no data to tell us exactly how long to wait. Also, different COVID patients are different in their disease course. Some of them were very symptomatic, required hospital stay. Some of them were very, very symptomatic, hospital plus ICU. Some of them had a very long ICU course and ECMO and so forth. And some of them were just had some mild symptoms and stayed at home. So it varies. It depends what kind of symptomatology that it presented with, what kind of issues that their body had, and did they really develop and build a full-blown ARDS or not, and other organ dysfunction, organ failure as well. Based on all that, we'll evaluate, and we'll, I guess, a thorough pre-op evaluation process looking at different system organs in the body would be able to help us tell whether we should allow them to have the procedure or not without having a specific cutoff like 2 months, 3 months, 6 months. Do you have anything to add to that, Dr. Driggs and Dr. Schweitzer, please? Leo, would you do anything differently in your ASC?
No, I agree with everything you just said.
Dr. Schweitzer?
I concur.
Thank you. We'll move on to the next question. Where can private practice look to obtain testing kits? Dr. Rodriguez, I think that's in your...
Where to get testing kits?
Yes.
You call the local lab that works at the nearest hospital, and they can guide you to you know, in my area we have Quest and LabCorp are the major labs, and so we go to them, and each area has their own dominant market player. I'm sure Dr. Rubin would concur with that.
Yes, in Cleveland, we actually have a reference laboratory, so we take on testing for hospitals that don't have testing. But you're right, Quest, LabCorp, Mayo Clinic, ARUP, there's a variety of opportunities, and so you just have to figure out who you want to use and establish a relationship with them so you get good kits and, you know, good turnaround times and everything else.
Yep, they usually send you free kits. They send you a box of enough with approximately like 100 testing kits. And then there's training that you have to take on how to take the sample, because that's where a lot of the false negatives come from, that people don't know how to take the sample. And then you know, make sure that you have access to the results. So I have access to the results of the samples of all the patients that come to my facility, and I can check it online to make sure that the patient can start the bowel prep or whatever, depending on what procedure they're doing.
And I have a couple of questions about office-based anesthesia. One of them say, what advice do you have for office-based practices engaged in purely elective, example, cosmetic surgery? Should we even be thinking about reopening yet?
I don't think the time is right. I think in phase 1, we should be doing patients that have been delayed for weeks and they need their procedures first, and then we can start thinking about electives in a later phase. But if somebody works in an office-based environment, I would take the same precautions that we take in an ambulatory surgery center. I would look at the prevalence, would look at what type of procedure they're doing, and each facility should have, if they're a licensed office facility, they should have an engineer come by at least twice a year to check the airflows of the environment, and that way they know how much to wait between cases.
We talked about, yeah, that was the question actually. When you're providing office-based anesthesia in room without any special airflow, like the OR airflow? How do you determine the safe time between cases?
Well, again, if you go to the website of the CDC, you can look up the term infection control guidelines and enter the word aerosolizing or environmental, and it'll take you to a page where they have each category. And under aerosolizing, they'll tell you the speed. You know, in general, let's say a waiting room is going to have 2 air exchanges per hour, and that usually accounts to about 138 minutes wait between one procedure and another. So they can do some engineering where they can improve the flow, but it requires work. But it's for patient safety.
A mental break from questions about testing and airflow. Do you think there will be full employment for all previously working anesthesiologists?
Of course.
Awesome.
They can't do procedures without us.
Dr. Schweitzer, what do you think?
Well, I think that's a really good question, actually. You know, I think that studies have suggested, or some evidence suggested, that patients aren't engaging in healthcare. Even in states that have opened for business, patients aren't particularly eager to come back. Patients aren't visiting emergency departments even when they're having strokes and myocardial infarctions. So it will be very interesting to see whether, I think the American public has been quite addicted to healthcare. That may be too strong of a word, but I think that people, you know, at the end of the year, they want to get their healthcare so they can utilize their insurance dollars. And I often think, well, gosh, if you didn't need it like 6 months ago, why do you need it now? Or really, you know, it's like, so I think it will be interesting to see whether we are doing as many particularly sort of routine, you know, sort of elective cases, knee replacements, you know, bariatric surgeries. I don't know.
Thank you.
I don't know
So
what your holds.
I think as a healthcare industry, we have to regain the trust of our patients in keeping our healthcare facilities. And I remember Dr. Hick saying not COVID-free, probably COVID-safe would be the appropriate expectation. If we're able to do that, we will regain their trust, and they will be coming back for their care. And at that point, there will be a return of all the jobs for all anesthesiologists and more. Because sometimes delaying care may add more problems, unfortunately. So it might end up requiring a lot more care. We're getting close to our end of our time, but I would like to, because of the recording and such, so if anybody has to get off the webinar, that's fine. We understand you have other obligations, but if you want to stay with us for additional more minutes for the recording, so as we can answer a few more questions, so for those to be available for those who ask those questions. Leo, is it okay to use Supernova mask for GI right now if they're COVID negative?
I don't know what's a supernova mask.
It's a special type of CPAP mask. Dr. Schweitzer, the nasal CPAP. So I guess you do not use it. Okay. Dr.
No.
Schweitzer.
I don't use it either.
Correct. I believe it has the same issue with the CPAP mask if it has any leaks, and also cover the nose only so the oxygen can escape from the mouth. So as potential for aerosolization also, especially that we know that the nasopharynx has a higher viral load than other areas of the body. So I would wait on that for, but again, that's personal opinion, not based on science or the studies and so forth. Just we're trying to, as you see, the common pattern in our answers, that we're trying to use the best available knowledge and information with our experience in clinical practice to come up with the best recommendation to the best of our knowledge. Unfortunately, there's not a whole lot of studies done in COVID. It just happened a few months ago. Even a lot of the data we're working with is not really well done data or studies. Even the ones that are published in bigger journals, unfortunately, they're not of the highest quality, but that's what's available. And if you're going to wait for highest quality, we might lose a few lives. So try to get the best out of what's available try to apply that to our knowledge. And as you could see, there's difference and variability in order and practice and diversity out there. If you do not have negative pressure rooms in freestanding GI facility, how do you effectively manage the risk of COVID exposure in those cases? And do you use ultraviolet light for disinfection?
So again, you have to A, screen the patients, know the prevalence in your area. B, you have to test patients, so you have to decide which patients you're going to test and which ones you're not going to test. So in my facility, for instance, we test every single upper endoscopy. We don't test the colonoscopies. That was a consensus that the facility arrived to. Everybody wears N95, so we're protecting our staff, and then we wait the appropriate time according to the airflow, and we're cleaning the floors. So, but again, you have to make a decision. We cannot tell people what to do. Each facility has to have a consensus among their leadership and develop a philosophy of how they want to manage their patients.
Got it. Our pre-op expert, Dr. Schweitzer, pre-op testing all PEDS patients, was that what you would recommend? To pre-op test all PEDS patients?
I believe the recommendations for preoperative testing have not given age limits. There is increasing evidence that even, children are at risk for contracting COVID at a much lower risk than older individuals. I think I saw one study that suggested that up to about 15% of children were completely asymptomatic when tested, and their symptoms can often be quite mild. And this is starting getting into allergy season, right? So maybe a few sniffles or snuffles could be thought of as merely allergies. So the recommendations would apply to children as well. I do want to say something about your local and state laws. I don't know if Illinois is unique, but our governor has mandated that every patient having procedure be tested for the coronavirus within 72 hours of a procedure. So, in some places it is mandatory to test.
What is the general consensus on anesthetic care during ECT during this pandemic?
I think ECT is often a life-saving intervention for many patients. So we have not stopped doing ECT. We limited the patients coming in for ECT to those who are felt to truly need it, to either be an emergency situation or a time-sensitive or urgent situation. So I think you just take the same kinds of precautions that you do with everyone else, but I don't think that one should be denying or not, agreeing to provide care for those patients.
Sure. Dr. Rubin, electroconvulsive therapy is being done, I think, in 2 to 3 times a week for many weeks till they show recovery. If we test them today, for example, for their treatment tomorrow, how often should we be testing them? Every week or every other day or every? What are your thoughts on that?
Yeah, unfortunately, there's no guidance, and anybody's guess. People wonder how often. We're actually working with businesses who contact us and say we want to bring a bunch of guys back into our business. We want to test them. How often should we test them? And there's really no good answer. I would say more testing is better. The president of the United States gets tested every day, I think, which, that would be ideal. If all of us could be tested every day, that would be great, right? But we don't have those kind of resources. And so I think that you have to kind of steward your resources. But yeah, sorry, but I don't really have a great answer for that.
Well, that's absolutely fine because there's no such answer. I just wanted to pick your brain on that to see if there's any particular guidance you would give us. For cataract surgery, Bobby Jean, why we are proceeding with cataract surgery with no testing for COVID-19. Can you advise if this is standard of care or not?
I don't think one can opine about standard of care regarding anything about COVID-19. So I think that, as you have mentioned, that, you know, there's quite a variation. I think Leo, everybody on this panel has talked about how, you know, if you're in one area, if you're doing certain cases, things are maybe very different. So again, I think everybody generally is recommending that if at all possible, you should test patients before procedures. Cataracts are often considered, you know, sort of elective procedures. I think for many patients, again, I don't think it's a life-saving procedure or, you know, that urgent of a procedure. But we do know that when patients cannot see, they are more likely to have falls. They're less likely to be able to manage to take care of themselves, to take their medications. And so eyesight is a very important, you know, mechanism that we need to try to maintain for patients.
Thank you.
I would say, you know, ideally you're going to be testing patients and practicing some of the things that we've gone over here about, you know, how you manage the anesthetics and the use of oxygen and masking. But I would not say that I would preclude patients having cataract surgery as a general, you know, group.
Yeah,
Thank you.
I mean, you know, I agree. I don't think cataract surgery is an aerosolizing procedure. The patient is going to be kept under a drape. So I would weigh in that if there's not much prevalence in a community, I would not do the COVID testing. I mean, because we have to think, what are we going to accomplish by getting the COVID test? So I think that if we're doing a major procedure like a total joint or lung surgery or heart surgery, that may have a larger impact on the patient's physiology than putting eye drops on the cornea and doing a 10-minute lens exchange under topical anesthesia.
There's a question about elective ENT. What are your feelings about doing elective ENT cases when you reopen, especially airway cases? We deal with them the same way. Testing ENT, especially airway surgery, are considered aerosolizing. So we still like to test them. If they're positive, we will do the usual, send them for care and wait. If not emergency, if it's emergency, you have to do what you have to do with special considerations. But elective ones, if they are negative, we accept them. And again, during intubation, extubation, and various parts of the operation with aerosolizing, especially if you're doing endoscopy, sinus endoscopy, and so forth, you may want to wear it for the whole case. There's another question about, is there any added benefit to modified aerosol box for the EGD? I've talked about that, addressed that in my last presentation, last webinar. I thought that the importance of the aerosol box or the intubation box is to make the provider, the anesthesiologist or anesthesia provider, and the resident feel good that they're doing their best to protect themselves from exposure. But as far as it has many issues, including make it awkward to intubate, it makes intubation longer, it may add difficulty to it. And imagine if you face difficulty with intubation and the box is in the way. What are you going to do with the box and how are you going to interfere emergently? That may add to the risks of aerosolization. And if also you remember that this has to be sanitized and disinfected after being used. And some of the boxes I've seen have angles and this and that makes it difficult to clean. And they have some things around the holes to kind of decrease the aerosolization, rubber pieces cut and so forth. to clean those carefully and so forth may make me feel like if there were any viral particles there, if I did not catch it during exposure, I may end up catching it during cleaning it. So my suggestion to folks is do your best in terms of doing thorough, careful intubation by providing a good level of anesthesia and adequate muscle relaxation. I think if you do that for a patient, you will decrease the aerosolization and extubation. Use the standard maneuvers and techniques and tips that we use in ENT surgery in general to avoid cough and bucking, because we do not want to see neck hematoma or bleed from the sinus and so forth. And if you do that for all cases, you'll be better off rather than using an aerosol box. I think now we'll get to the end of our webinar tonight, but I wanted to give opportunity for our panelists. Any final thoughts or words of wisdom? We'll start with Dr. Rubin. Do you have any final thought or line of wisdom for our attendees, please?
I don't think I have any wisdom. I've been really enjoyed this session this evening. It was great to hear what's going on in the world of anesthesia. I think that my fellow panelists are really smart, really professional, just amazing people. And so I really enjoyed hearing your responses to questions, because I've been hanging out with pathologists a lot. So thanks so much for inviting me to join you this evening. I really enjoyed it.
Absolutely. Thank you for joining us. And we likewise, we think you're very smart, and we appreciate all the information you gave us today. Dr. Rodriguez, do you have any final thoughts, please?
My final thoughts are keep your patients safe and your staff safe, and think about the consequences of the things that you do, and if you think of other people, everything will be fine. I'd like to thank everyone for attending this webinar. I hope that you're SAMBA members, and if you're not, please join SAMBA. We have facility-based membership, and you can take advantage of several of your providers at your facility can join SAMBA. And our mission is to educate and assist all physicians to succeed in ambulatory surgery, NORA, and office-based surgery. Thank you.
I'll say thank you. Dr. Schweitzer, any final thoughts or words of wisdom, please?
Well, I really appreciated being part of this panel, and I've also learned a tremendous amount by listening to my fellow panelists. I think Dr. Rubin said something that I want to reiterate, that I often feel safer actually when I'm at work than I do going to my local grocery store or other places around the community, because I do think that I'm lucky enough to be in a place where we are taking, testing seriously, providing people with enough PPE. And I think just, keep remembering why we all went into this profession. We went into so we could take care of patients. We're lucky to have jobs. We're lucky to be in a position where we can offer care to those who need us. So, stay safe, keep your head about you, but, it's offer care to patients.
Thank you. Thank you very much. Appreciate it. My final thoughts is as follows. We have put in some statements for you of what we see as the best case scenario for the current state of knowledge, that what we know. Try to get to that, but if you can't have it all, as a wise man once taught me, if you can't have it all, do not leave it all. It's just guidance there for you. We recommend testing all patients, but if you can't, test as many as you can and do your best with other interventions and precautions, and you'll be all right. And I just want to say last line, hang in there. This too shall pass. And we'll see you next week on Monday around the same time and same station, as they say. We'll send out the invitations to you. Thank you all for joining us today, and big thank you for our panelists. You guys are fantastic. You have enlightened me today, enlightened others. Good night, everybody. Take care.
Stay safe.
Bye-bye.
Good night. Thank you very much, everyone.